Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be doing another Kahoot, and I'm going to be covering fractures. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give it a thumbs up now so you don't forget. Subscribe to my channel if you haven't done so already, and don't forget, I'm now offering next generation NCLEX reviews and one-on-one consultation sessions and tutoring sessions. If you're a current student and you are struggling, you have to get a really high grade on your next exam. I made the audio lessons just for you. I made audio lessons for students who are struggling in particular subjects in nursing and they have to do well. So you can reserve your spot for review, a one-on-one tutoring session, or get yourself an audio lesson by going to my website, nexusnursinginstitute.com. Don't forget, you can find me covering a variety of nursing topics on my other social media platforms such as TikTok, Instagram, and Facebook. Okay, guys, without any further ado, let's get started. Fractures. Skin over this type of fracture remains intact. Is it a closed or simple fracture? Is it a comminuted fracture? Is it an open fracture? Or is it a spiral fracture? Skin over this type of fracture remains intact. What do you guys think it is? Those that were not able to make it into the Kahoot room, you can still answer on the live. Just type in your answer. All right. That's right. Closed or simple. Most of you guys got this correct. So when the skin remains intact, this is a closed or a simple fracture. Now let's talk about the other types of fractures. The other choice, which is comminuted, that is when the bone fractures are in little pieces, right? They're tiny little fragments. Open or compound is when that bone breaks, but it protrudes through the skin. So guess what? Who do you think is going to be at higher risk for infection? A person with a closed and simple fracture or a person with an open or compound fracture? It's going to be someone with an open fracture. Why? Because there's no protection. The skin, which was a barrier, is now open. And a spiral fracture, that is the break in the bone that is in that circular motion, okay? Whenever you guys get a test question and in the test question, you see the patient has a spiral fracture, you need to suspect abuse because usually what happens is they have that spiral fracture from that twisting motion, okay? Next question. Which is not used for skin traction? Which is not used for skin traction? Here's our choices. Sling, Russell traction, elastic bandages, skeletal traction. Which is not used for skin traction? Georgia, the name of the app is Kahoot. Okay, wow. So let's talk about this. When it comes to skin traction, guys, slings can be used, Russell traction, even elastic bandages, but not skeletal traction. I noticed 5 of you guys chose skeletal traction. So when we're using skin traction, guys, the skin is intact. This is not invasive, right? There's a pulling force on the skin. When we're using skeletal traction, we're talking about, pins, wires, even tongs that have been placed directly on the bone. That means this is invasive. So when we're talking about skin traction, we're talking about something that's short-term, non-invasive, such as a sling, Russell traction, or elastic bandages, Bucks traction. Those can be used for skin traction. True or false? A closed reduction involves a surgical intervention. Is this true or is this false? A closed reduction. Does this involve surgical intervention? True or false? Very good. Most of you guys said false. So remember on the first slide, we talked about types of fractures, right? And we talked about, I talked about the closed fracture where the skin is intact, right? So if that skin is intact, Why are we going to need surgical intervention? So with a closed reduction, no surgical intervention is needed. What happens is that bone is manipulated manually. There's no invasive procedure. Select all that applies. Which is not an intervention for the patient that has a cast. So we're looking for what's not an intervention for a patient that has a cast. Select all that applies. Here's our choices. Keep the cast extremity elevated. Handle a wet plaster cast with the fingertips until dry. Infrequently monitor for circulatory collapse. Monitor for symptoms of infection. Teach the patient not to stick objects inside the cast unless itching occurs, and teach the patient to keep the cast clean and dry, which are not interventions for the patient with a cast. If you guys are not live, you're watching this from YouTube, go ahead and press pause if you need a little bit more time. Okay, let's talk about it. So let's talk about the correct answers first. We're looking for things that are not nursing interventions for the patient who's in a cast, and it's going to be 3 of them. You are not going to handle a wet plaster cast with the fingertips. Absolutely not. What are you going to handle them with? Your palms. Because what happens is when you use your fingertips, you can cause indentations in that cast. Now that indentation can press on the tissue, press on the muscles, press on the nerves, and we could mess around and cause that patient have compartment syndrome. So we're not going to use the fingertips. We're going to use the palms of our hands. We are not going to infrequently monitor for circulatory collapse. We are going to frequently monitor. Okay, that those 2 letters, the I and F, made this question this answer absolutely wrong. I said infrequently. We're not going to infrequently. When you infrequently monitor a patient, that means you don't do it often, and you have to monitor that patient often. So that's incorrect. And the last one, we are not going to teach the patient to stick not to stick things down the cast unless itching occurs. It doesn't matter if they're itching or not. They are not and should not be sticking anything down the cast. No pens, no hangers, no rulers, no nothing. What you're going to teach them, if you know that area is itching, they can either pat it if it's dry, or they can take a blow dryer and put it on cool, not hot, but cool setting to help relieve the itching. But under no circumstances are they to stick anything down the cast. Now, here is what you are going to teach the patient. You're going to teach them to keep that cast elevated. Why? We want to decrease swelling. We want to decrease all the fluid rushing to that area, because remember, the cast is not going to expand. We're going to teach the patient signs and symptoms to monitor and to report. You as a nurse, you're going to monitor for signs and symptoms of infection, but you're going to teach the patient those signs and symptoms to report. You're going to be watching out for hot spots on the cast. You're going to be, watching out for foul odor. You're going to be looking at the labs. You're going to make sure those WBCs aren't increasing. And last, you're going to teach the patient to keep the cast clean and dry. We want to decrease the risk of infection, and we want to maintain the patient's skin integrity under the cast. How are you guys doing on the live? Faris Khalaf says, I'm dead. No, you're not dead. You're learning. This is a good thing. All right, guys, next question. Select all that applies. Your patient has a bone fracture and they're in the cast. Which signs and symptoms of circulatory impairment would you be alert for? Here's our choices: pain, swelling, discoloration, tingling, warmth, hyperactivity. So your patient has a cast. What are the signs and symptoms of circulatory impairment would you be watching out for? Again, your choices are pain, swelling, discoloration, tingling, warmth, hyperactivity. Okay, let's talk about this. So the first answer is pain. When circulation is decreased, that means there's not enough blood flow going to the tissues. What is in the blood? Oxygen. So if there's not enough blood going to the tissues, there's not enough oxygen going to the tissues. So the tissues are going to be screaming for oxygen. They are going to be screaming for the vitamins, minerals, and nutrients that are found in the blood. So what is that screaming? The pain the patient feels. So yeah, they're going to feel pain. Once there's decreased circulation, it's gotten to the point that the tissues are suffering, that patient's going to feel pain. True. Swelling. Yup. Decreased circulation, that fluid's not moving. So guess what? It's going to accumulate in one spot. You're going to see swelling. Absolutely. Discoloration. Guess what? Your skin's nice and pink because of blood flow. So if the blood's not circulating the way it's supposed to be, instead of seeing the skin pink, that area is going to be what? Pale, or even worse, blue. Tingling. That's the paresthesia, that tingling sensation where the patient feels like pricks and needles. That's also a sign of decreased circulation. Not warmth. Warmth would be a sign of infection. And not hyperactivity. I just made that up. I threw that in there. Okay, you're not going to see hyperactivity in the patient. So, guys, think about those P's that you would be assessing for decreased circulation. You'd be checking for pain. Paresthesia, that's that tingling sensation. Pallor, that's the discoloration. Paralysis, that's where they can't move the extremity. I'm missing 2 more P's. Poikothermogenesis, that's the feeling when you touch a patient's skin, it's supposed to be nice and warm. That warmth comes from the blood flow. So if the patient has decreased blood flow, it's going to feel cool, or even worse, cold. And I'm missing a P. What's the P? Oh, pulselessness. Duh. Instead of feeling a strong pulse in the extremity, the pulse will be weak, or even worse, absent. And I know I said 6 P's, but I'm going to tell you one more thing that you'd be watching out for. It's not a P, but you definitely need to be watching out for. It's going to be the swelling, the edema. Okay? Select all that applies. What are the possible complications of a fracture? Avascular necrosis, compartment syndrome, fat embolism, increased intracranial pressure, pulmonary embolism, osteomyelitis. What are the possible complications of a fracture? Okay, let's talk about it. So the correct answers: possible complications for a fracture, avascular necrosis. Guys, that is death of the bone tissue from lack of oxygen, which is carried in the blood. So when the bone tissue is not getting enough blood supply, it will start to die off. That is your avascular necrosis. Yep, that absolutely is a complication of fracture. Compartment syndrome. By the way, compartment syndrome is a medical emergency. That patient has compartment syndrome. They have to be rushed to the operating room immediately, and you expect a fasciotomy to be ordered because you have to relieve that pressure. Fat embolism. Let's talk about it. Fat embolism, those fat globules, where are they hanging out? In the long bones. So the patient has a fracture in a long bone. Those fat globules are going to be in that bloodstream. So absolutely a fat embolism is a complication. Pulmonary embolism. Okay. Blockage of that pulmonary artery from, an occlusion such as a clot. And of course, osteomyelitis. I think I spelled osteomyelitis wrong, but you guys know what I meant. Osteomyelitis, infection of that bone. Absolutely. All of these are complications of fracture, but not increased intracranial pressure. You would expect increased intracranial pressure to be a complication in something like a traumatic head injury, right? But not a bone fracture. I just threw that in to throw you guys off. But I'm happy only 3 of you fell for it. Good job. Select all that applies. Your patient is suspected to have a fat embolism. Which actions would be expected? Are you going to notify the healthcare provider? Are you going to administer oxygen? Are you going to monitor their respiratory status? Are you going to administer IV fluids? Are you going to assess for mental status changes? Or at this point, Professor D, I give up. I have no idea. Your patient suspected of having a fat embolism. Which nursing actions would you expect to be taken? Okay, guys, very good. Everything except for I have no idea, I give up. You expect to assess your patient, especially for mental status changes. We want to make sure they're getting enough oxygen to their brain, right? We're going to check them for mental status changes. We expect to give them oxygen, IV fluids. We're going to monitor their respiratory status. We want to make sure they have a pulmonary embolism. Of course, we're going to notify the healthcare provider, give them our assessment, and see what orders would be, what the healthcare provider is going to order. True or false? The distance between the axilla and the arm piece of crutches should be 4 to 5 finger widths in the axilla space. Is this true or is this false? The distance between the axilla and the arm piece of the crutch, it should be 4 to 5 finger widths. Is this true or is this false? Wow, this was close. Okay, so let me tell you guys the answer. That is false, okay? It needs to be 2 to 3. So about 2 to 3 fingers width between your armpit and the top of that crutch. That's how much room there should be between, not 4 to 5. True or false? The elbows should be fully extended when crutch walking. Is this true or is this false? False. Very good. You try to crutch walk with your arms fully extended, you're going to topple over, okay? It needs to be slightly flexed. You want it slightly flexed around 20 to 30 degrees, but not fully extended. Very good. True or false? When going upstairs on a crutch, the affected leg goes first. Is that true or is that false? You're on crutches and you're going up the stairs. The affected leg goes first. Is that true or is that false? Very good. That's false. Remember, guys, good goes to heaven. So when you're going up to heaven, you start with the good leg, and bad goes to hell. So when you're going down the stairs, you start with the bad leg. Okay, very good. Which should be avoided after correction of a hip fracture? Leg alignment, hip alignment, leg abduction, or leg adduction? All right, so it was a tie between leg abduction and leg adduction. So let's talk about the difference. Leg adduction, ADD, that's when you add things together. So leg adduction would be adding, putting those two legs together. We do not want that. You are going to pop that hip, right? We don't want that. We want leg abduction. We want the legs separated. That's why when the patient has a hip fracture, they have an abduction pillow because we want to keep the legs separated. We don't want to pop that hip out of the socket. So we are going to avoid leg adduction. We want leg ab with a B, abduction. We want leg alignment and we want hip alignment. Following a discectomy, your patient must be turned. What is the minimum number of people it will take to do this? Is it 1, 2, 3, or 4? Your patient just had a discectomy and they need to be turned. What is the minimum number? What is the minimum amount of people that you'll need in order to do this? 1, 2, 3, or 4? Very good. 2. So your patient had a discectomy, all right, and they need to be turned. Guess what? They have to be log rolled. You cannot log roll a patient by yourself. You cannot log roll with only one person because you have to avoid that twisting motion. So you're going to have one person at the head of the bed and one person closer to the bottom. So when you turn them, that patient turns as one unit and you can avoid that twisting motion. You want to log roll the patient. The first 24 hours after a lower extremity amputation, how should the extremity be positioned? So it's the first 24 hours after the patient's had an amputation. How are you going to position them? Elevate the foot of the bed, lower the foot of the bed, elevate the head of the bed, place the patient prone. It's the first 24 hours after amputation. How should they be positioned? Very good. Elevate the foot of the bed. Why? We want to decrease swelling. We want to bring that blood flow, the fluid back to the heart. We want to decrease swelling. So that first 24 hours, you're going to elevate the foot of the bed. True or false? 24 to 48 hours after a lower extremity amputation, the patient should be positioned prone to prevent hip flexion contractures. Is this true or is this false? It's true. The first 24 hours, guys, you're going to elevate the foot of the bed because you want to decrease that swelling, but you do not want that patient to have hip contractures. So what you're going to do is place them prone because what does that do? That forces that leg where the amputation was to what? Extend, and it helps prevent the risk of flexion contractures. Hi guys, thank you so much for watching this video. Please don't forget to let me know what you thought about the video. Let me know in the comment section. Did you like the this whole activity in the Kahoot format, or would you like me to go over content in a lecture format where I'm teaching out of the book, or would you prefer me to cover content in a question answer format, such as the videos that are released every Sunday at 1 p.m. Eastern Standard Time? So please go ahead and sound off in the comment section. Don't forget, almost daily, you can find me covering a variety of nursing topics across my social media platforms. My handle's still the same everywhere, Nexus Nursing. You can find me on TikTok, Instagram, and Facebook. One last thing, don't forget, I'm now offering next generation NCLEX review sessions, one-on-one tutoring sessions, and consultation sessions. If you're currently in a nursing program and you are struggling, go check out my website. I have audio lessons available for you. You can get all of that information by going to my website, nexusnursinginstitute.com. Guys, thank you so much for watching this video. You guys will catch me on the next video.